All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. It helps, these exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
now.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So
Indeed.
Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello, everyone, and welcome back to the GynoCast. My name is Dr. Eric Heegaard, board-certified obstetrician gynecologist. I'm here with Twila Dang, my
Hello.
wing person, co-host, my boss.
You can actually call me a wing woman. It's okay.
I'm never exactly sure what to say about that, but you're
I'm
my
a-
boss.
I'm a
Can I
woman,
say you're
I'm
my
okay.
boss?
Yeah, you can say that too. You know, I don't mind being referred to as the overlord in charge.
The overlord, that's right.
So
The lady of the manor.
It's fine. I'll take that.
And for those of you who are new to the GynoCast, welcome. We appreciate you listening so much. I hope you'll join our Facebook group and become part of our little family.
Absolutely.
We adore you. We love you if you're new. And if you are a repeat listener, we love you as much but differently.
As he likes to say.
And we are, if you're listening right now and you are a new or recurrent listener, we are wrapping you in a nice warm GynoCast blanket of something. I'm not sure.
Yeah, me neither, but that's okay. What are we talking about today?
Okay, we're jumping into that. You're just not going to let me wander.
Give the people what they came for, sir.
So, God, I feel like I'm coughing a little bit right now.
You're all right.
Are you coughing?
I'm fine.
Dr. Grootwassink, you coughing at all?
I'm
Is this
good.
great?
You're
It's because they were making me laugh. So on the GynoCast, we talk about things that are important to talk about, but oftentimes we don't know where to go. And so you go here. That's the answer. So we have done a show on kind of basic infertility workup, evaluation, and that sort of thing. And we're going to, and so please look at our, where should they look?
They can go to the website at matriarchdm.com and check out the syllabus. For today's episode, I will put a reference link back to that original episode.
Yeah, so you can kind of get the basics. So we're going to continue on with more kind of advanced treatment of infertility. And Dr. Grootwassink from OBGYN West, the best OBGYN group in the universe, is here to talk about this. He is... I'm going to say probably the most active fertility doctor we have at OBGYN West. There's a number of us who enjoy doing it, but you're kind of our spearhead.
Okay, I'll take that.
Okay.
Compliment.
All right, doctor. So why don't you tell us?
Yeah, tell me a little about infertility.
So he's referring back to many years ago when we used to do live radio. I had not prepared quite as much as I should, and he came in the studio and I basically said, "So, just tell us about infertility," and kind of didn't, that's kind of a wide, what is the word?
I don't actually know where you're going.
All right, well, anyway. Okay, so let's talk about infertility. So I want to carry on from what we talked about before. We've done the evaluation of somebody. We've done all the testing, et cetera. Now we are talking about treatment. And so why don't you kind of take us through the decision tree of how you decide to treat somebody that we've determined is infertile, or couples that are struggling with fertility.
Well, where I usually start, and you try to keep it as simple as possible, is you basically need a sperm, you need an egg, you need a place for them to meet, and a place for them to land. And that's...
I have known you for like 20 years, and you've never told me that before. This is just fantastic.
That's what I tell people. This is what we need.
Okay, can you repeat that?
You need a sperm, you need an egg, a place for them to meet, and a place for them to land. And that's
fantastic.
And that explains,
everything.
Well, it is. That's how we do things. So, unfortunately, I wasn't privy to your first show about the evaluation, but you'll do certain basic lab tests that look for reasons why somebody is not ovulating.
So I actually want to just jump in because that is a perfect explanation, because those 4 different steps. Basically, when we're doing an evaluation, we're trying to figure out, okay, you need a sperm. Okay. We're looking to make sure there's sperm with the semen analysis.
Yep.
Is there an egg? Well, we make sure they're ovulating.
Right.
And what was that? They needed a place
of meat and a place for them to land. So you meet at the very distal portion or the far end of the fallopian tube.
So we make sure the
tubes are open, and then they have a place to land inside the uterus.
There you go. So that's our evaluation. So, and just to jump a little bit ahead, because to make it simpler for people, because I don't want to waste too much time, but if somebody doesn't have sperm, that's a different decision.
That's right.
And if they don't have any sperm at all, you're gonna.
They need to talk about donors, or if they've had a vasectomy, there are ways still to get sperm. More of a minor surgical procedure, but you need sperm, and if you don't have them, you have to find them somewhere.
So why don't you? So you're sitting down with a patient, and one of the more common reasons why people have trouble getting pregnant is they don't have regular periods. They don't ovulate, release an egg on a regular basis. What would be the discussion you would have with somebody like that?
Well, and that's the thing that that people need to understand about trying to get pregnant, because that message is out there. Well, you should try for a year, and say your periods are every 3 months.
Yeah,
you're wasting your time trying for a year. I mean, the likelihood that you have success just isn't there. So what I usually talk about in history is, again, going back to history is a very important thing as far as evaluating anybody.
Talking to people?
Talking to people. You can learn.
Amazing.
You can learn enough, usually just by talking. But 35 days. If your periods are longer than 35 days from day 1 to day 1, you're probably not ovulating, and that's where we would focus.
And we define day 1 as the first day of
the first day you
period,
bleed.
So.
Yep.
And so, okay, so somebody's I want you to take us through the conversation of how would you talk to somebody who's not releasing egg on a regular basis?
Right. So you try to figure out why. There's some issues. You can have elevated substance use like prolactin. You could have a thyroid issue. You could have polycystic ovarian issues. I mean, there's a number of reasons why people don't ovulate. So what we usually do is draw what we call day 3 labs. So on the 3rd day, day 1 being the first day you bleed, actually bleed, not spot, but bleed, draw blood on day 3, and that'll give you an insight into ovarian reserve, what kind of status your ovaries are, how they're going to respond to any medications you might give, and you look for other reasons why they wouldn't be ovulating.
So all of that's available from a blood test,
several blood tests. Yeah.
Okay. Wow. I didn't think about it being that sort of in that length, that amount of detail in terms of when you're doing initial tests.
You can. I mean, if you couple that with somebody's history, you can learn a lot just with that little snapshot.
Oh wow!
And these things, if they're abnormal, like if thyroid is abnormal, some of these other hormonal tests are abnormal, we can manage that, by giving supplemental thyroid medications.
Right. You correct the problem.
And so so in somebody who just doesn't ovulate or release an egg on a regular basis, and it's not due to a thyroid issue or something like that, what would be the medications that you would start talking to the process?
Well, I even before medications, you got to look at the patients themselves. I mean, you talk to the IVF, the reproductive endocrinologist, or even the people who do this a lot. There is a significant correlation between fertility issues and obesity. I mean, it's there. Yeah. So when you're counseling these people, you don't immediately say, "Oh, here, take a pill and I can fix everything." I mean, you go back to the things that everybody hates to hear, diet, exercise, and you can make some lifestyle modifications that will not require medications.
Right.
But that's where you always want to start there, because you need the people and that to be helping you. And that will help guide you for what medication you're going to use. And
they don't necessarily have to lose a tremendous amount of weight.
No, I mean, usually it's the ironic thing is if you have somebody who's not ovulating and they can lose 5% of their body weight, 5%.
Yeah, so you don't have to lose.
You don't have to suddenly get down to a BMI of 20. You lose 5% of your body weight. A lot of times is enough to start you ovulating again.
Yeah, so you don't have to go from a size 13 to a size 5.
Right. And I think usually anytime you hear, and as a woman, I know anytime I hear anybody tell me we should talk about how much about losing some weight, some in your head immediately turns to half of your body weight, and you start to panic.
Right.
Yeah.
Well, it's a sensitive subject too, and it's hard to talk to people about their weight. And most of us, okay, I'll just include myself here. I've struggled with my weight, and it's just if you're heavier than you want to be, you know you're heavier than you want to be.
Right.
Yeah.
And so it's a topic that is takes some finesse.
Well, and the last thing you want the patient to leave your office thinking, well, I went to this guy to see why I can't have a baby, and all he did is tell me I was fat.
Yeah,
that's not how the conversation wants to. You need that to end.
Mm-hmm.
But that it is a key component because you can't. It's much more difficult to help people that aren't helping themselves.
Right. And no matter what your situation is, whether you're talking about for whatever reason a couple's struggling to get pregnant, if the woman is heavier, losing a little bit of weight, 5%, for example, will help everything, not just ovulation issues, but it just helps the whole process, no matter what the underlying cause is.
Well, yeah, and they're trying to have a baby, and you want them not only to have the baby, but to be around as the child grows. And I can't think of a more motivating thing in somebody's life as somebody who really wants to have a baby. It's like, geez, I need to make some lifestyle changes to help so I can get pregnant and I can, be the mom and be there as the milestones of the child's life.
That's right. So you've kind of counseled them about this, and perhaps they've lost some weight. Where do we go from there?
Well, again, you're looking at the patient, so kind of the drugs will fall into a couple different categories. The ones that everybody knows about are like Clomid is the classic one. These are Clomid and Letrozole, which is actually Femara is another name for it, is actually a breast cancer drug, but we use it to kind of soup up the system, so to speak, to increase ovulation.
And those are pills.
Those are pills.
So people love that because they're pills.
Yep. It's a pill you take in the early part of your cycle, days, say, 3 through 7, 5 through 9, in that ballpark.
And so is this something that how many, I'm going to use the word cycles, but I'm not sure, how many months, for example, would a couple try this particular treatment?
It really depends on your results of the cycle, not just from a pregnancy standpoint. But the issue with these drugs, whether it's Clomid, Letrozole, if some is good, more isn't necessarily better. Yeah. So we start at a lower dose, and it may not work the first time. And then you bump it up a little more, and you bump a little more, because the side effects can actually interfere with the ability to conceive as well. So, but if you can get 3 ovulatory cycles, so you have released an egg, and you can look at the lining of the uterus, and it is good for implantation. 3 cycles, 90% of the people that you're going to help are going to be pregnant within those 3 cycles. You kick that up to 4 cycles, and now you've got 95%.
Yeah, so within 4, unless there's a reason why it's being delayed, within 4 months, 5 months, you can get a sense of whether this particular modality is going to work.
Right.
You don't need to do it for 2 years.
No,
because we see people who've been doing it
for 2 years. Somebody come in and say, "I've done 15 cycles of this," and you're like, and then they haven't been monitored, so you don't even know if they've ovulated yet. That type of thing. So that's when we do it. We you look at the beginning to make sure you're not going to cause any harm.
Actually, do that and just tell us what. So the patient has her period. Just kind of quickly.
How we do things?
Yeah.
Mm-hmm. So if you're doing a stimulated cycle, for what we do, we usually have you come in and do a baseline ultrasound, so we know we're not causing any problems. You don't have a cyst in your ovary that we're going to give you medication, make it bigger, or cloud that picture when we get to day 12. If you have a 2 millimeter follicle or a 2 millimeter cyst in your ovary, it looks exactly like a perfect follicle.
So if you have that, where the egg is
the egg is living. So if you have that at day 3 and you go back and look at day 12, you don't know if your drug did anything or it's still there. So we do the baseline ultrasound, then you start the medication, ideally as early as you can. Day 3 is where I like to start, and then usually 3 through 7 or up to day 5 through 9. Have them come back about day 11, 12, a little bit earlier if they're going to do an insemination, or you get a little more wiggle room if they're just doing a natural intercourse, and then repeat an ultrasound. And you really look at how many follicles are. So you can tell somebody, because everybody's worried about, well, what are my chances of having twins or being octomom because I'm taking these drugs.
Right.
You can look at the ultrasound and say, look, there's 1 egg. And then you look at the lining of the uterus and say, yep, it is exactly where you want it to be. And the number I shoot for is 7 millimeters. I want at least 7 millimeters in the lining. And then we can actually give them a drug that will make them ovulate at a set time, literally, so they can time intercourse or do an insemination to virtually the exact same time they're ovulating.
So going back to your metaphor, and we are ensuring that they are we're making sure that they meet and they land in a hospitable environment.
We have the egg because we can see it. We make sure it shows up because we give them a drug to make it release. We have the sperm, whether it's an insemination or intercourse, and we know they have a perfect place for them to land. What we can't see on an ultrasound is that distal portion of the tube where they have to meet.
Right.
But hopefully in our workup in advance, we have established that the tubes are open and those type of things.
So this leads to we have all seen, those of us who do this, situations where people have had these medications and people are not watching them with ultrasounds and that sort of thing. What is the concern with that?
Well, there's two. I mean, the one that really shouldn't enter into it, but it does, is how insurance treats infertility. A lot of people will have you have 6 cycles, lifetime, and somebody says, here's a prescription for Clomid, 50 milligrams, 5 refills. They use it. They don't get pregnant. They have used their entire insurance benefits for their infertility lifetime.
Wow.
And they've done nothing.
Right.
And we have no information. We have no idea what, and it works for some people. That's the thing.
Yeah.
It's enough that it works. But if it doesn't work, we've learned nothing and they have nothing left.
Right.
Wow.
So that's the one thing. And then you're asking me why we monitor? Is that where we're
Yeah.
What are we talking about again?
Yeah, so I think I'm going to paraphrase what you said about the importance of trying to optimize the use of a person's
Right.
resources, financial and emotional and all that.
Yeah.
The reality is infertility treatment's expensive.
Right.
I mean, it really is. And in this day and age, as the government's getting more and more involved in healthcare, money seems to matter a lot more. So being able to do it right, because if they don't have coverage, they're paying for it themselves, and you don't want to sit there and waste somebody's time and waste somebody's money.
Right.
Because this is something they want. By the time they see me or you, they wanted a baby a year ago.
Right, exactly. And it's emotionally exhausting for, even under the best of circumstances,
Right.
this is hard
Absolutely.
on people.
Now, when you say is that pretty common sort of amongst your understanding of the insurance industry that for infertility, when you're dealing with like infertility drugs, that it's sort of that's kind of a low set number?
It's really varied. I mean, it's so variable that within our office, we actually have somebody from our business office sit down with every single couple that's going from an infertility standpoint, so they can understand not only our costs but their benefits. So they're sitting down with somebody who actually speaks insurance company and can go through and say, this is what this means. This is what you have. This is your benefit. If you have 6 cycles, or you have a $20,000 lifetime max, or you have in a very rare circumstance, you have IVF coverage. So they know that. Because you want to work together at this and trying to help people understand what benefits they have or don't have, so they can choose the ideal therapy for them is I think paramount in this discussion.
Do you oftentimes see people sort of get their hands tied by, this is what the insurance will do for you and this is what you can do, and then you kind of have to make decisions more based on not always like this is the best thing for us, but this is the best thing financially for us?
And financially and ethically. Mm-hmm. You see both things, or people just say, you know what, I will not do IVF. So you fall into that category where they've done their 4 cycles, or they've done enough cycles that statistically the likelihood that they're going to have success is down into the single digits, but it's better than them doing it by themselves.
Mm-hmm.
So yeah, there are. I mean, a lot of people. There's a lot of, you get your hands tied behind your back all the time.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
Wow.
So one of the other reasons why we monitor is to ensure that, as you mentioned before, Dr. Grootwassink, not wanting to have an octomom.
Exactly. I mean, people that talk about infertility, they worry about that. And I can always bring my own experience, because I say I have twins, and you don't want them. You want, and I mean, my kids are great, and the twins are fine. But we had 3 kids under 2, and I kind of remember that year. And but it's one of those things that if you can do it one at a time, it's healthy for the baby, it's healthier for mom, and you can control that. Because that's a lot of people, when they get into the infertility, they watch the reality shows. That's one of their biggest fears.
And it's important. You want to know how many you can potentially have.
Exactly.
And 2 is is a tough pregnancy. When you start getting to 3 and above, you're talking about a significantly high risk pregnancy.
Well, 2 babies, your average gestational age at delivery is 36 weeks, so that's a whole month early. Yeah. You add 1 extra baby, now you're at 32 weeks. So you're 8 weeks early, and a 32-week baby is going to potentially have issues that are lifelong.
That's right.
And there's going to be 3 of them.
Yeah, that's significant.
Yeah, it's sobering.
Well, I mean, just in the thought of and especially when you talk about sort of the emotional aspect of a process like this, when I've had a lot of friends that have gone through this process, and there is that sort of roller coaster of, I just want to have a family. And then you kind of get to this stage of it, and you're sort of right at the precipice of really taking action. And then you sort of get paralyzed by the idea, okay, I said I wanted a family, but now there's the potential here to have
an insta family.
Yeah, like a really and truly, significant, shift of, you're prepared mentally for 1 baby and you're barely mentally prepared for that. But the idea of, I know a woman had triplets, and it was overwhelming. Right. And there was a lot of one of their babies has a lot of health issues, right. And that takes you out of the realm of, we wanted a family and this is what the path we took to get it to. We have now made this major life choice and change, and it has now shifted the way we're going to live our lives for the rest of our lives in a way we never anticipated.
Right. Well, and then have that conversation early. It's a hard conversation to have, but when somebody who's been trying to get pregnant for 2 years and really wants to have a baby, and they say the first time you gave them some medication, nothing happens because you start low, and then you bumped up, and the next time they have an overwhelming response.
And by that, you mean
now there's 5.
5
Wow.
And you're like, okay, we're not doing anything this cycle. You need to, no intercourse, no insemination. We're not doing anything. And this is something they've wanted for years. And it's like, oh, we want to have a baby. And now I've never ovulated in a long time, and now I'm about to, and I can't do anything about it. That's a tough conversation to have, but it's the responsible thing to do, as opposed to just giving somebody drugs and saying good luck.
Yeah.
So the important, what we're going back to is the importance of, and these medications are very successful and very safe, but they got to be watched. Well, and this is important to be.
Talk to me a little bit. I guess as the lay person in the room, talk to me a little bit, sort of from that ethical perspective. Do you feel like that? I guess that's. I remember one of the main conversations that we all sort of had when we watched things like Octomom, and we watched like the like John and Kate +8 was, who allowed that to happen? How do you even get to that point? Do you feel like there's or that on some level it's been addressed, sort of the ethics of allowing things like that to happen within the industry?
I think a little bit. I think it's the hard part is when you move up, and especially in the IVF realm. IVF centers have to report their data, their success rates, their pregnancy rates. Okay, so, and it's a published thing, and that's how people find out, I'm going to IVF, I'm going to find this person has the highest pregnancy rate. Mm-hmm. So things would be pushed. I got to get my pregnancy rate up. And then the single embryo transfers, where you're only putting back 1, can have a negative impact on that, which is the ethical thing to do. Overall, it's going to decrease the cost for healthcare. It's going to healthier mom, healthier baby, but economically could hurt the center because they have a lower pregnancy rate. Mm-hmm. So there is a lot of the ethics that go into it, and I think that it's a hard conversation to have when you tell somebody they can't do something, but you have to be able to do that.
Especially when they're paying out of their own pocket.
And you finally got them to ovulate, and you say, you can't do anything this month.
Wow, that is I can't even imagine.
This area of gynecology is fraught with high intensity emotion, and they're excited, they're optimistic, they're grieving, and there's a whole grieving process.
It's an emotional roller coaster every single month. It's going to happen this month, and it doesn't, and then you go up again, and it just. People say the emotional toll of a diagnosis of infertility is worse than being told you have cancer. Yeah.
Well, I guess that brings up a good question for me. In this process, in a process of working with a couple and attempting to help them get pregnant if they are diagnosed with infertility this way, Is there a psychological component? Is there a sort of a psychological, like in terms of treatment component of like recommending therapy, recommending psychological evaluation, in terms of like giving them support? Because I can't even imagine how I was fraught as a person who could get pregnant under regular circumstances. I can't imagine the burden mentally of that on top of everything biologically you're going to go through to get there.
Oh yeah, definitely. And there are psychologists that specialize just in this area. A lot of IVF centers actually require an evaluation by a psychologist prior to an IVF cycle.
Oh, I just feel like that would make sense because you can't.
Oh, it's like I said, it's an emotional roller coaster, and it can destroy relationships. It can make people do all kinds of crazy things.
Mm-hmm.
So this goes back to about the importance of I just want being maybe a better word for it would be an efficient use of people's resources, because it's not just money we're talking about. We're talking about emotional resources as well, and people get exhausted and end up, as Dr. Grootwassink was saying, a strain on their relationships, a strain on their whole life. And so we want to make sure that we're being efficient with their resources and getting them pregnant as fast as possible.
Right.
And so you don't want to have things drag on.
Right. Another thing, and it brings to something I also say virtually to every couple I'm dealing with, is time is not your friend.
All right.
Every month your fertility does decrease a little bit. So you do, to that point, you do want to be as efficient as you can. You want to get as much information as you can. So if the cycle doesn't work, you know why it didn't work, and you can modify it going forward.
Exactly.
Doing the same thing over and over again and expecting a different result, that's
madness.
Exactly.
That is the definition of insanity.
So, as we were talking about the pills, letrozole or Femara and Clomid, these are often what we start out with for many different types of, whether you're talking about somebody who doesn't ovulate all the time or maybe a mild male factor. And we use that for a lot of different issues related to fertility. And sometimes we'll add an insemination on, depending on the circumstances. What happens if after 3 or 4 cycles they're not pregnant? Where do you go there?
Well, you look for, what are we missing? That's the big thing. And if it's 3 to 4 cycles when they've ovulated versus cycles where they didn't ovulate, it makes a huge difference. If you max out these drugs and you don't get a response, how I usually, a lot of people go to the injectable medications. And how I describe the injectables is Clomid basically increases your follicle-stimulating hormone in your body, the hormone that makes the egg.
So that's the signal. I'm just going to jump in here because most people don't know that, but that's the signal that your brain sends to your ovary saying, make an egg.
Right, and in simplified terms. So the injectable is a little vial of FSH.
Yeah.
So in essence, it's taking the safeties off. So you use Clomid or letrozole, your body has to do it. Your body has to make the FSH to get the thing going. And it's not going to do anything not in its own best interest. Whereas the injectable medications, we can pump you through it, and despite what your body's going to do or try to stop, you can a lot of times overcome that. That's where you get the, 8 babies kind of thing is usually in those drugs.
It's stronger, more direct stimulus.
So you take your multiple rate in like a Clomid or a letrozole about 5%, and then you use injectables. That number can spike into the 30s.
So that's why it's so important to be watching and knowing how many eggs you're producing.
Absolutely.
Right? Yeah, I've told people this for probably 10 years from an infertility standpoint, that I think the injectable aspect of fertility will go away.
Yeah, we'll eventually just go.
You just stop doing it. The hard part about it is if we get you to ovulate, we still can't beat nature. Your success rate is 15-18% per cycle.
Okay, so that brings up another. Before you get into that, because that's an interesting thought, and we've talked about this before, but why don't you explain to people who are listening to this, what is the baseline chance of getting pregnant per month, depending on a person's age? It's surprising for many people.
Well, yeah, I usually tell people that if you're 2 18-year-olds on a desert island, you've got about probably a best case scenario, a 20% chance of conceiving in any given month.
Yeah.
So if you put everything right together perfectly, it's still only about a 20% chance it works.
That means 80% of the time, if you're doing everything right, you're not going to get pregnant every month.
Exactly. It's a completely opposite message that you got from health class. If you thought about having sex, you're going to get pregnant.
Well, yeah, you panic.
Yeah.
You don't have to tell
now,
us.
Now, mind you, we're not going to play this the podcast for anybody under the age of 18.
Yeah.
They don't need to know.
But that's why we give people a year oftentimes, or
Right.
6 months to a year if they're otherwise healthy. We don't have another reason for it because it's an odds thing. You know,
Right.
even if you're only getting 25% per cycle, if you try every month for a year,
You're going to get it.
you're going to get it.
Yeah.
Right.
And so, but I think people are, I think, always kind of surprised how really kind of bad we are as a species at getting pregnant. And, you know, an 80% failure rate under the best of circumstances, it's amazing we have 6 billion people on this planet. But I think it just says how often people try. They try a lot. They don't realize that they're playing an odds game.
No, that's probably about as efficient of an explanation of that as you could come
They
up
try
with.
a lot. And so when you're talking about the success of a cycle of Clomid or letrozole or even injectables,
Right.
oftentimes we're trying to kind of get people up to what may be normal for their age.
Right. Well, and before I go to injectables, you go back to that. What are you missing? You know, and everything that we can look at, we can see the egg, we can see the lining, we can see the sperm. What we can't see is the distal portion of the tube.
Right.
And a lot of times before I will go to do any injectable medication, if somebody's been ovulating, you do the laparoscopy, you do the surgery, you physically look at the tubes, and we look for things like endometriosis, adhesions, signs of previous infection, anything that could be hampering you.
So you don't necessarily start out with a surgery.
No, I
But it
don't.
may be something
I think surgery is a big deal.
Yeah.
And so I always hate it when I actually have to sit down with somebody and you review their history, and it's like, geez, I'm meeting this person for the first time, and I'm going to tell you that I think you need surgery. That's not a good thing.
Yeah.
But that's what it needs sometimes.
Because we gotta know what's going on. If it's
Again,
not clear, we need to know.
And why waste your time? If your tube is bad, if the tube is the focus of your problem, I can't help you.
Right.
You know, you have to bypass the tube.
Right.
And then that's in vitro fertilization.
So, what would be the circumstances that you would use injectable medications, that direct stimulants, as you were talking about? You know, in what particular patient population would you go to that after the oral pills?
If you have somebody with some resistance, or say they use their oral medications, they get to a certain point and it seems to just fall off. I do a lot of kind of combo cycles where you'll start with the pills, evaluate things, look at, and that's where we draw some blood draws during it. We're seeing how much estrogen those ovaries are making as a response to, as they make follicles, they make estradiol. So you can draw that, and then you can kind of nudge them up further. You know, you've taken them so far with the oral medications, and then push them to the finish line with the injectables.
Right.
That's when I probably use it the most. The straight injectable cycles, we still do, but you know, as you use those medications, the cost goes up a lot. Your success rates, you know, really don't.
Right.
And you can have such a much more dramatic impact with in vitro fertilization as far as their likelihood of conception, that a lot of times I will steer them in that direction if that is an option for them. But if they say we're not doing IVF, that's the population that I use those injectable medications in.
So, take us a little bit about when you're talking about IVF, in vitro fertilization with patients. And can you kind of go through the process of what that entails? Because I think a lot of people, you know, it sounds pretty high-techy, science fiction-y, and it kind of is, actually.
Well, it's a baby in a test tube.
Yeah, but it, you know, I think they think it's, you know, more intimidating in some ways than it really is. I think one of the real advantages of it is that you can, instead of having somebody going through cycle after cycle after cycle after cycle for months after months and months, you compress things and hopefully get them pregnant faster.
Right. So the big fundamental difference between what we would do with Clomid or letrozole or the injectables is we're trying to tease out that dominant follicle, the one or two that you can get released to get pregnant. IVF doesn't want that. They don't want a dominant follicle. They want it, you know, every month, the 20 eggs that are trying to be ovulated, they want all of them. So they initially will suppress your ovarian function, something like with a birth control pill, which people think is really odd. You just go on a birth control pill to get pregnant, but it shuts your ovaries down. And then they bring up all of those eggs at once, usually using the injectable medications.
that we were just talking
about. And they use much higher doses than we're going to do because they have the advantage that those eggs are not going to stay. So once you get the eggs to a mature level, they will literally use the same medication that we do to induce ovulation, the Ovidrel or the HCG shot, to stimulate the LH surge that your body naturally has. And then we go in and remove the eggs. Use an ultrasound through the vagina. We can access the ovaries and pull out all of those eggs so they can look at them under a microscope, take a look at them. Then they'll get a sperm sample from the partner, and literally, under most cases now, they do what's called ICSI, where they literally take a single sperm, they put it into the egg, so it's not dependent on fertilization, and then they watch the embryos grow, and they've gotten very good at it. They can say, good, not so good, and then they put back the best ones. And then you literally freeze what's left. So, in essence, if you say you pull out, you get 12 fertilized embryos, you have done a year's worth of infertility in one cycle.
Right.
You put 1 or 2 back, you freeze, say 4 or 5 that you still have left. 2 years later, you come back, and then you literally can have twins born 2 years apart because they're conceived basically at the exact same time.
Right.
So the risks that we have as you get older, as far as Down syndrome, those kind of things, don't affect it because the embryo doesn't age.
Yeah, they're stuck at whatever.
The egg was a certain age when it came out.
I think this is one of the actually most impressive things about this technology that enters into the conversation we have with our patients now that we didn't really talk about 10 years ago for sure,
No.
which is, you can bank your fertility. And that's what Dr. Grootwassink is talking about.
Mm-hmm.
If you're 37 years old and you want to have 3 kids, under normal circumstances, if you're lucky enough to get pregnant on your own, well, you get pregnant, you are pregnant, you deliver your baby. By the time you're looking for number 2, you may be 39. If you go through this process with IVF and you get pregnant and you've frozen 4 eggs or whatever, those by the time you are trying to get pregnant again, those eggs, which are maybe 37 eggs of a 37-year-old, are still there, and you give somebody the opportunity to perhaps continue to build their family. When under normal circumstances they may not be able to do it because they've run out of time.
Well, and that the technology has actually advanced a great deal. In the past, we could do just the embryos. I remember way back when I was a couple years ago when I was a resident, where the embryo freezing was just starting out at the university I was at, and it just wasn't working. They went a whole year and didn't have a successful one. Now the frozen embryo rates are basically almost the same as the fresh.
Yeah.
And we've gotten good at freezing things. The egg is a very delicate thing, and we couldn't freeze it and have a viable egg. And now the technology is there that you can have somebody who, say, is 30, 31, 32, and no prospects, and it doesn't, it wants to have kids, but just isn't in a place in their life that it's going to work, can literally bank their eggs and come back and fertilize them with a partner that they choose several years later and still have eggs that are 32 that aren't going to have the risk of Down syndrome, et cetera. And it can change people. A lot of people that wait and wait and wait and then never get to have kids, you could change that story by banking the eggs when they're 30.
That's right. In a perfect world, I think, I don't know what your thoughts are about this, but, we were talking about the pills, letrozole, Clomid, and that sort of thing, but I think a lot of these people, you do a few cycles of Clomid or letrozole, and if they're not pregnant, you go, as you were saying, right to IVF instead of spending a lot of time with perhaps other modalities, or just have people go directly to IVF.
Well, and if they're not ovulating, you can find a reason that they're not getting pregnant, and you can fix it, and you can help a lot of people that way.
Yeah.
But you're going to help a lot of those people in the first year. You're not going to help those people 3 years into it.
After keep banging away at the same thing.
And that's the hard part, and it is hard, and you do struggle to say no to some people, to say, look, you've done I'm not helping you.
That's right.
And it's a very hard conversation to say that we need to do something different. Doing this over and over again is not going to help you because they're so focused on it, but they live in a world that has certain restrictions, and IVF is expensive, and not everybody can afford it.
Yeah. It just made me think of, and this was maybe a year ago, I think it was last year, I delivered 2 babies where the moms were both, that just happened to be the same age, which was 45, that had been frozen since they were 39 years old.
Wow.
2.
Yeah.
So those embryos were frozen for 6 years, and that allowed them to get pregnant at 45 years old, which you know that under normal circumstances they would not be able to continue to build their family.
Oh no. Well, and they had that was with the Hurricane Katrina in New Orleans.
Yeah.
They had there was actually a cryo facility there that lost power.
Is that right?
And people went in and rescued the embryos, in essence. And there have been children born from
Is that right?
from
I
embryos that
didn't
were
realize
rescued from that facility that were
Wow.
when the power went out.
Well, and again, I want to just go back to what Dr. Grootwassink was saying, this idea of freezing embryos, which is exciting in and of itself, but the idea of freezing the eggs, which is just, it's kind of mind-blowing and is changing the whole conversation people have about how and when they build their families.
Right.
Because I was talking to a doctor who had come up here to Minnesota and was doing egg freezing, and she was, I think, 35 years old, but she did not have a partner. She was very involved in building her own medical practice, but she wanted a family, and so she was going to bank her eggs so that so that 3 years or 4 years or 5 years or whatever down the line she could build the family she wanted without having to necessarily be under the constant pressure of the fact that she's getting older.
Well, and don't you, I guess I see from the perspective of the marketing person and the person who's doing all this demographic research for my own business, that there is a shift, particularly among sort of the millennial generation, of putting off these types of decisions and life changes until far later down the road. Their mindset going in is they understand the technology is there, and they understand the lifestyle that they want to give themselves before they even employ that. It's not even thinking about like family planning later. It's, I can bank my eggs and do this at this point, and then we'll do the rest of that later. Like they're sort of even skipping the step that my generation, which was more, I want to be married by this age, I want to have kids by this age. They're not even sort of thinking that in that way. They're really thinking in terms of understanding what the technology can do now.
Yeah, it's really exciting, and this is exciting times. So what sort of success are we seeing in terms of in vitro fertilization, just in general?
In general, it's age based. I mean, the younger you are, or why you're having issues with pregnancy. But I usually will tell people that in most circumstances, it's well over a 50-50 shot, even in just one cycle.
Right.
Under the average infertility patient that I'm seeing.
And again, just to go back to what we were talking about, as Dr. Grootwassink was saying, at 20 years old, you might have a 20% chance of getting pregnant every month, and with IVF, you're talking about over 50%.
And 50 is being very
conservative.
Very.
Yeah. And so this technology is there, and so the important thing, I'm just going to kind of reemphasize this, I think, is the importance of being proactive depending on where you are in your life. And if you want to have a family, depending on your age, you want to get in and see somebody who knows what they're talking about and is going to help you be efficient with your resources, both emotional and financial, to help you achieve that. And so, as you can tell from our conversation today, there's a lot that goes into this in terms of deciding what technology to use, what modality to use. But the exciting thing is that under most circumstances, we can work around just about everything.
Yep, you can, with the exception of,
age.
I mean, even in that instance, there's people who we do donor eggs.
Yep.
So, yeah, you can accomplish just about anything with donor eggs, donor sperm, surrogates. Somebody to carry the baby. You can, well, we talk. You need an egg, a sperm, a place on meat, a place on the land. We can pretty much do without one or two of those things and still make it work.
That's right. So if you want to get more information on Dr. Grootwassink, please go to the Matriarch website, which is matriarchdm.com.
Well done. It'll be
Thank
on the
you very
syllabus.
much.
We'll have everything from today's episode available for you on the syllabus as well. And don't forget to go to Facebook if you haven't already joined the GynoCast Facebook page. Just type in the GynoCast and request to be a member. If you are already a member, you can continue the discussion there. You can pose more questions and future topics if you have those as well. And you can even send us a message. Hit the Send Message tab, and it will give you a private message that will come directly to us, and we can answer it for you.
That's right. All right. Thank you, Dr. Grootwassink. Thank you, Twila Dang. And thank you for listening, and we will see you soon.